So I do, in the beginning, talk about MI as a way of being. I'm going to share with you that understanding that these ideas are all ideas that have come from Stephen Trzeciak and Anthony Mazzarelli. So I want to give that to them. And I have put in some of their research resources in here, but there's, like I shared with Heather, there's like 500 of them almost in here, and I wasn't about to go through and figure out all of them. So they are certainly available in the book for anybody to have a look at. So I do show my gratitude for them in bringing this to me, because I have found it to be extremely useful. One of the things I use it for is when I've done a training and I'm coaching a team at a location, I modify this for whatever they do and bring it to them when we have the deep dive into compassion, because so much work was done here. So let me start. That's one of the things I put up in the beginning for folks that have had the MI, just to have a conversation about what comes up to the top for them, where would they like to go, and mostly just to note that compassion is one of the pieces that we look at in motivational interviewing. And I put this up too as part of the way of being, so I'm not going to put all of you through that. This is the systemic review, the first time done with all the data on the impact of compassion. So I do mention that in the beginning. They certainly did do a really broad look at this across many, many years. One of the things they start out doing is talking about why we would care about this. And I have two areas that are my areas that I do a lot of my work in. One is trauma responsive care, and one is motivational interviewing. And I find the compassion aspect of it to be probably the most important piece that I bring to people when I'm doing my work. So I do like to notice that unlike what we knew or thought we knew, Darwin did not put that kind of idea across of survival of the fittest. That was not his. That was someone who read his work and said that. In fact, in his work, if you look at it, and there are some questionable things that he had said over the time that he did this, but the kind of solution or outcome that he has around this is that compassion is actually there because it protects our species. We would not survive without that interdependence, and that interdependence depends on us being able to have compassion for each other. Just what is it? So compassion is the emotional response to another's suffering followed by an authentic desire. And I found that interesting because one of the things in Bill and Teresa's book on effective psychotherapists was that genuine piece, right? One of the aspects of being effective was genuineness. And certainly it seems very, very important with the compassion as well. And there's the way that William Miller and Steve Rolnick define it. And I think we are in healthcare and human service working to benefit the folks and bring that safety and trust, which is part of being trauma responsive. So this is really interesting. One of the things they did in the book was look at burnout in physicians, particularly, and nurses actually, and talk about it at length about how compassion is different than empathy. And so they had a functional MRIs done as people were experiencing both. And what they found was that in empathy, it lights up our pain center, not a surprise, experiencing the other person's pain. And that when we move to compassion, which is more the behavior than the feeling, it lights up our reward center. And what they found was it lights up the other person's as well. Even while they're still in their pain, there is a reward that we both get. And this is kind of the key to what they were talking about, how we need to be interdependent with each other. And that's how we do this for each other, is through our compassion. It also is very important when it comes to burnout, and we'll talk about that. One question they have is there decreasing compassion in our society? I might put that out as a question to all of you, and feel free in the chat or somewhere to give your response about that. Are we becoming more self-focused and less focused, but this is the research that I found really interesting. Looking at our youth, 2/3 of our youth feel their parents do not value caring for others as much as they value achievements and accolades. That moved me in a rather deep way. And I would say probably it may not be that the parents really do, but it may be the youth's perception. And Heather, I'd be really interested in your thoughts about that as you work with youth and adolescents all the time.
Yeah, I think it's a really interesting finding because we all hear about the folks on the sidelines at the athletic events and how intense that can get. And also, I think in general, I feel our society is achievement oriented. And so maybe more so than others. And so I feel like we're constantly in this like encouragement of our kids to be the best, do the best. So I do feel like that, I guess as a parent, I try to do something a little bit different, but certainly I fall into that trap as well, like when something comes home that's like not quite what I would have expected for performance, I'm like, I try not to get too absorbed by that, but yeah.
Yeah.
Go ahead. Can I ask a question about that? Because I'd be interested in the populations. Is whether this is true of all socioeconomic. I mean, when I sort of work with kids in poverty, there's this sort of tribalism, and where caring might be more foundational. In my certainly white middle class family and raising two kids who are achievers, I probably reflect that. But I was just wondering if that's true of all socioeconomic classes.
That would be really interesting research, I think, to look at that across, because I'm sure when we're in more of a survival mode, we're going to see something different.
Yeah, and I'm guessing communal, societies or cultures are a little bit less achievement oriented.
Yes.
So yeah, that would be very interesting.
And actually, I think I may have written something. I'm just going to, I'll leave it and we'll go back to it. I can look it up, the reference to this. I think this came out of Harvard. And so it was middle school and high school kids. That I remember. Mm-hmm. So I'm going to go to that burnout piece and the empathy and compassion if I can, because this is another reason why they feel so strongly about this need for compassion, and I'll explain it as we go along. So what do we know about burnout? We know it's an emotional exhaustion, the feeling that one can't make a difference, and the inability to make that personal connection. Sometimes even our training, and I know that there's a book called Caring where the physician talks about how it kind of gets trained out of us, empathy, in the process of becoming what we become. So the question, of course, is, and again, in our society that we're in of competition and comparison a lot, but I ask the question, is this a job or a calling? I don't know. I'm just asking the question as they do too. And then just another thought about it. Are we role modeling compassion so that those with whom we work and often mentor learn the same? And I think when I'm speaking to all of you who took the time to become Mint members and believe in the work that Bill and Steve have done, and it likely matters a lot to us, but I'm sure if we looked at the general population working on healthcare, that may not be the case. And some of that will be their own stress and challenges that they have within healthcare. So when they asked, they went to a number of physicians, a large number of physicians, to ask them why they might miss the opportunities for compassion. One was, I don't see the opportunity. I don't have time. Time is a big issue. I don't care. I don't know how. And I think that's key. And that goes back to, Heather, what I said to you about, we tell people that compassion is really important, but we don't always help them find it, how to do it. And I don't believe it really matters was another piece of it. And that could be where we specialize too. And I'll talk about that a little bit later too. But I think that matters what we do. Certain areas lend themselves to more compassion than others in healthcare. So one of the things they did as they looked at the data then was that when we have the science of this art of compassion, we have better outcomes. They found that the outcomes for the patients were better, lower costs, and it's pretty profound to look at the differences, and more resilience for service providers, which went to less burnout, which is really the focus of this, is to understand that when we bring compassion, we actually reduce burnout significantly. And excellence and compassion go together, get the best outcomes. And so we're going to look through the physiological, psychological, enhanced self-care, and increased quality of care. So the first thing they talk about with physiological effects is the lack of human connection increases our susceptibility to a lot of things. And I didn't write them all, but this is from one of the pieces of research. They just found that when we were lonely, we were more likely to have a cold than other people. Loneliness really is very, very hard for us to, especially older adults, really difficult. People who suffer a heart attack and have no emotional support were 3 times higher odds of death. And just the noting in the research that they had done, that compassion actually reduces the stress response and heals. And this is something that I learned a long time ago about trauma and stress, is that that's often the thing that is creating higher risk for death and illness. So what does it bring? Well, here's this positive things they talk about. The touch lowers our blood pressure. It promotes healing. So when they looked at physical trauma, the odds of a good outcome were 4 times higher when the physician was rated as having high compassion. That's quite a difference. Compassion reduces perception of pain, including all of the more chronic kinds of things, back pain, headache, irritable bowel, that kind of thing. And it builds trust. It is trauma responsive. It is something that helps us connect in a relationship where people can interact with us in a healthy way. They looked at diabetes specifically, and I thought this one really mattered, and I pulled it out. And I'm sorry for how it's not looking that good in the picture there. It's usually dark blue. I don't know what's going on, but we'll go with it. The odds of optimal blood sugar control were 80% higher when they had high compassion physician, 80%. And the odds of serious complications were 41% lower with high compassion physicians. That
Cheryl,
is, yes.
It's very dramatic and striking, and I'm sorry for interrupting, but can we ask some questions as you proceed? Or
you may, absolutely, yes.
I don't want to bog us down, certainly in methodology, but this is a very exciting presentation to me. I bought the book and I've looked through it, but have not gone. It's great to hear the way you're dealing with this granular level. How are we measuring the high compassion physicians? Is that can I ask that?
Yeah, they have a tool that they use. Yes, measuring compassion, and I don't have that up here. I didn't pull it up either, but there is a tool that they use across. Yes, and you'll find as we go forward, there is a company called Empathetics, where it's on my PowerPoint. The physician that leads that company does a lot of work with helping to build compassion of healthcare workers as part of what her mission is, and they use that tool too.
Thank you.
Yep, and I can get it for you if you want to see it. Oh, I want to just go back to that for a minute. Why does that matter? When I think about the work that happened with trauma and Dr. Anda and Dr. Felitti, and Dr. Anda was at the time the head of chronic diseases and prevention, I think, at the CDC. And this to me says that, we all know how challenging it is to work with chronic illness versus acute illness. And I think in healthcare, we've created a system that is more in tune to acute illness. Our patients are usually happy with us. When we fix the broken leg, we sew up the laceration, we give them the antibiotic they need. But that's not how it works in chronic illness at all. There is no fix that's immediate and complete. So it is really a partnership with people. It seems to me that this is the kind of way of thinking about this and understanding this is really important to take into all chronic illnesses. That when you bring this compassion and relational piece, you make a difference. And just the bringing of it makes the difference in many ways. And I've seen that actually and we don't have time today with this, but with a person with diabetes that I helped at a primary care office, I was just there to show them motivational interviewing with him. He was willing to have me do that. And just the difference in his response to what he was usually doing when his hemoglobin A1C was elevated was profound. And he brought it down within about 3 months. Somebody partnered with him and saw him as the expert, and it really made a difference. So I think that matters in all the care we give. There is a story in here, which I might quickly say, if I may. We don't have a lot of time, but it's about a doctor who actually was very, very ill in ICU. He almost died. This is early in his career. It was in 1972. And this is what he said when it came time for him to start thinking about breathing on his own again. After weeks of being on a ventilator in the ICU, I could tell right away when a new nurse came on duty, whether or not they cared. If it was a nurse who cared, I would instantly feel stronger. I believed I could beat this and breathe on my own again. And that's Dr. Edward Viner that wrote, and he's the head of a number of things around compassion and care now. And I don't have that in front of me, but important that it was somebody who experienced it. And interesting because I had an experience when I was 19 and I was a student nurse at the time where I got appendicitis and then had peritonitis pretty significantly close to death too. And those were before the days of hyperalimentation and all of that, back in the dark ages. And I had the same experience as a patient, that I had nurses that really cared and I felt like I could get better and get out of there. And I had some that I felt I didn't even want them in the room because it felt a bit scary and not safe. Anyway. That is my own story that matches his, probably why I find his so interesting. There's the piece that I was talking about, and she has a TED Talk called The Power of Empathy. Dr. Helen Rice, or Reese, I'm not sure how she pronounces it. She's the head of that company called Empathetics that I talked about, and she's on the East Coast. Compassion relieves psychological pain, so we're looking at psychological now. The most effective psychiatrists obviously augment their neurochemical effects of antidepressants by bringing compassion. And we know already, and this is important with MI, when you think about it, therapist compassion had a moderate to large effect on reducing depression symptoms. So compassion itself makes a difference in therapy when we're looking at psychological effects. It's a dose response. I found that interesting too, because they saw that in the ACE study, where the number of ACEs people had impacted their risk in the long term for all of the stress-related diseases and autoimmune diseases, all those things. Well, it's a dose response with this. We know it helps alleviate anxiety and distress and improves our quality of life. What they found was that every statement, in other words, the more we stick with that and bring our compassion to the patient, has a measurable and incremental effect. And I did put in there deep reflective listening, affirmation, and hope, which are our ways, I believe, and certainly I'm open to anybody else's idea of how we do it. With motivational interviewing, I think that is really what makes the difference.
Can I ask a question?
Yeah.
And maybe you're going to be getting more into it, but that idea of like, how do you know, when we're listening to conversations, what would get coded, I hate to ask a question like that, as compassion, specifically like, because, I give a lot of feedback on mock interviews. I do have a mock interviews is kind of main part of what I'm doing these days. And, it's funny because, you'll have people who are, they feel like the more empathic people of the group, but it's like, boy, there's a lot of stuff that you're doing. It's not reflective listening, but it's probably mostly compassion. And sometimes I just want to call it empathy, but there's a lot of I in it, like, oh, I can understand, or I can relate to that, and it's all this, it's warmth, but to me, it doesn't meet the standard of like really doing reflective listening.
Right.
So anyway, I wonder if that's compassion.
Yeah, I think the deep reflective listening is necessary for compassion because it says to them, I care and I'll give you time and I'm caring to understand you. I think that the affirmations, obviously, that I'm recognizing rather than noticing what you can't do and what you're struggling with, I'm noticing what you can do. And the hope, how I use the language that I would say right now you're not able or whatever it is, but I would use the language that says this isn't forever, right? And I think those things are, from my perspective now, we're trying to put two things together here. And what it is the active things that we do. That's the difference between empathy and compassion. Empathy is the feeling. Compassion is, I'm going to take this journey with you, walk beside you, and support you as we go through this. And that's the piece that matters. And I think it matters hugely right now in healthcare for our folks working in healthcare. When you hear some research that I had seen, and I'm sorry, I don't have that in front of me right now, but around burnout and in healthcare and in human service, 80% of it, the reasons were around systems, not the work they're doing with the patient, but the systems that get in the way. And when I talk to therapists, they'll say, well, I'm getting all this pressure from all these referrers that I need to make them change. I need to make them whatever. Some people will not change and will not change quickly. I believe that every minute that you spend with them listening and caring in a compassionate way is making the unbearable bearable for them. That is part of the healing, that they aren't alone. And so I stole that piece, making the unbearable bearable out of Compassionomics. That's a place that they have that in, because everything in healthcare we can't fix, right? But what can we do? We can make the unbearable bearable. And there it is. I also mentioned another place that does a lot of this work, the Swartz Center for Compassionate Healthcare. They refer to them a number of times throughout in the book. Compassion brings hope. It helps somebody feel like I'm not alone. This person believes in me, and they care about me. So it activates the people that we serve as well. Compassion is actually a motivator. It showed in the diabetes, right, that we were bringing the blood glucose down to, better than it had been, 80% better, and we had less complications. Those all matter because people have been activated to be part of the process with their physician and their care team. So non-adherence to prescribed therapy in patients with chronic disease accounts for a lot of money. 100 to 300 billion in avoidable healthcare costs. 20 to 30% of folks never pick up their medication, and 50% of the medications are not taken as prescribed. That is high, and that's a concern. That is not collaboration, is it? And compassion in the sense of I'm working with this person and they are activated to work with me. And they have found that this compassion piece of it is what helps to activate people to work with us. It makes sense. when I go in, and I'm, 74, so I get to go in as the older adult now. If I'm a checklist, I can't wait to get out of there. I cannot wait. And in fact, I've made a decision at this age that unless I'm something more than a checklist, I'm not going to bother going. So I think that it really makes sense when I feel like they care. And may I step back from that, because I understand the stress they're under. And I do understand that. So I'm not angry about it, or I just am choosing not to spend my time as somebody else's checklist. What do we know? When providers knew their HIV patients as a person, the patients had 33% higher odds of adherence to therapy and 20% higher odds of no detectable virus in the blood. So this is saying, again, this interrelatability, being compassionate, makes a difference in what people are willing to do as our patients. Adhering to health screening recommendations. So compassion helps people feel empowered to manage and understand their illness. It builds that trust, and it seeks to understand the people we serve and their purpose and why they get out of bed each morning. It also helped with quality care. And this was really interesting, looking at health systems and measuring how the patients felt about what was going on and what they really cared about. Even more important, in the research they found, wasn't a whole lot of data on high compassion and higher quality, but there was a whole lot of data on low compassion and lower quality. So there is big work there for folks that are interested in research to go in and focus instead on what is right than what we don't want, and see if there's a connection there as powerfully as they believe there is. And it is really protective. And I do have this burnout inventory available if anybody wanted to see it, but I'm sure you've all heard of it. Lately, it's been something people are talking about a lot. But lack of compassion in us as healthcare workers is a threat to patient safety. Depersonalization can lead to a lack of attention, lower quality standards, and a situation where things can happen that are not good for the patient. That depersonalization prevents compassion. In fact, that's why people do it, because they can't get out of their empathy. And when they can keep feeling the pain, but they have nowhere to go, which compassion is the way to go. That's that deciding to take that journey with them and be there with them and support them. When we don't have that, we lose most of the joy that we would have in the work that we do. So physicians who scored high for depersonalization were significantly more likely to commit a major medical error in the next 3 months. So burnout is dangerous for us and dangerous for them. What's important, being a patient means being vulnerable. And I know that quite well from that experience I had when I was 19. I had one nurse in the middle of all of this. I had all the tubes attached to me and whatever, who said to me, well, you're a student nurse, you can empty your own bedpan. I had a temperature of like 104 and could hardly even breathe. And I got that kind of response. That was vulnerable. I couldn't do what she even wanted me to do. And so it protects those who are vulnerable. Failing to be compassionate will increase the risk. And we know we don't want to cause harm. We look at costs. Patient experience supports the business that we're in. Hospitals rated highly also perform higher on patient experience, also perform higher. Oops, sorry about that. I'm just going to go back. Also perform higher on the financial side of it, and compassion improves that patient experience. It's worth it. So I just put the Cleveland Clinic Code Lavender in here by demonstrating compassion for the staff first, which is really important in all that work I'm doing in trauma now and toxic stress. Unless our staff feel safe and trusted and feel there is compassion for them, it is much more difficult and sometimes impossible to come with full compassion to the people they serve. It is a parallel process. So that's why Cleveland Clinic does this. Code Lavender is the code that says somebody in our building needs support, psychological support. They've just been through a really difficult thing. And it can be anybody. It can be the staff, it could be the leadership, it can be a patient, it can be somebody that's in the cafeteria, anybody in the building that needs that. When staff have compassion for patients, there's less spending at the hospital, not a surprise. And interesting to note, the factor that mattered most to the patient experience was that nurse-patient relationship. Of course, they're there 24/7 and they're the ones giving direct care, so it makes some sense. And I just have the link there to the whole business that they do around that. They have a great video, by the way. Have you seen their video on compassion? Any of you? No, they have a video. I'm just going to stop sharing for a second. Cleveland Clinic have a video that you can pull up. It's I think it's called Compassion, and I should have looked it up before, but I didn't. That's really well done, and they give
Excuse me, I've used that video in training.
Yes.
What I found was that when the pandemic hit, it didn't seem so relevant because it was kind of hospitals doing business as usual.
Mm-hmm.
But I've been thinking about how I might integrate that back into the training that I'm doing.
Yeah, thank you, Fran. I've used it a lot over the years as well. It's really well done. And they actually, what they do with that is they have all of their new people that come in see it, and they also do it on an annual basis, renew it and bring it up to date. And it's a focus of theirs. It is one of their major foci. Okay. Compassion accounted for 65% of variation in how patients rated their satisfaction. Compassionate physicians were perceived as more competent. Medical errors increase in the absence of that compassion and also cost the system money. And interesting this one, compassionate physicians refer less and order fewer tests. My guess is it's because they're really listening and they can make a better assessment and just spend that extra time with their patient. The patient trusted the physician, believed the physician really knew them and would be able to manage their emotional and physical health. It underpins better adherence to treatment. We know that reduces employee absences, well-being of physicians, lowers malpractice costs, and extra compassion reduce. I love this piece of research only because, you know, the emergency room and people that are unhoused and people who are intoxicated come in, and there's a lot of fear that, you know, if we're nice to them, if we don't put them in the corner and you know, then discharge them without really doing anything, that if we are nice to them, that they're going to keep coming back. The opposite happened. They decided that they would meet their basic needs, take care of them, give them the same attention as much as they could in an emergency room. And they actually had 30% less visits. That's interesting to me. It goes to all the stuff when Anda and Felidi wanted to do the ACE study, the IRB didn't want to approve it. You can't talk to people about their trauma, they say. You're going to upset them. They'll be committing suicide and rushing to the emergency rooms. None of that happened. 17,000 people answered it, and none of that happened. I think it's us sometimes that's afraid. And I think, you know, to be aware of that, that we assume that people don't want things that they do. It's the same with Espert, right? People really don't mind you asking. It's how you ask. And do you come with a loving and caring relationship with them? And I use that word liberally. I know I sound like a woman of the 60s. I am. So, but I really believe that kind of loving kindness matters to people. So here we go. So 40 seconds they found was all it took for that patient to believe that you really cared about them 40 seconds. So 56% of physicians believe they don't have time, and 40 seconds of compassion is all that is needed to make a meaningful difference to that person. It really can save time. What do we know? They can be learned. It is about behaviors. The issue we don't know is whether we can teach about the behaviors and help people do this, what we consider compassionate behaviors. We don't know if it actually helps us to care more about that person, right? And change the experience. One of the things I say to therapists all the time, they'll say, well, I don't know, I was saying the right words, but they don't seem to like me, or they don't seem to trust me. The challenge for all of us is that our facial expression, our voice tone, and our body language is what folks see. And if they're folks that had a lot of trauma in their childhood and over the years, substance use, I was the director of an inpatient rehab for substance use for 15 years. Those patients taught me what I needed to know, because they read you like a book. They needed to survive. And that's the challenge with teaching compassion, right? Can it become that real true caring for the person in front of you? There's the challenge for all of us. Okay. So I think we're almost done. What do we need to do this? Intentionality. It is something. We've heard this in the world of MI too. Intentionality is important. Managing our own emotions, that's our responsibility. It will make us a better healer. And Dr. Brene Brown says compassion's a commitment. It's not something we have or we don't have. It's something we choose. That's the difference between empathy and compassion too. Empathy, if you haven't turned it off or you never had it, you will feel it. But compassion is something that you choose to move to. Can it change clinicians' minds and who they are? It can. We have neuroplasticity. Hey, even at my age of 74, I can still do new things. I'm very excited about that. Intentionally treating patients with compassion can result in you feeling. So just practicing it can help you feel it more. And they found that. And then there's some ideas there of places that have done that. One in Germany, there's that company Empathetics again that I talked about. In 80% of scientifically rigorous studies, compassion training successfully increased physician, nurse, and healthcare student compassion. And interventions to improve that relationship are associated with better outcomes. We've said that already. The size of the effect of compassion was greater than the effects of aspirin in reducing incidence of heart attack, or the influence of statins on the 5-year risk adverse cardiovascular events. Which is interesting from that research that just recently came out about the difference for young women than young men that have had, everybody read that? That the women, and I can't tell you the exact percentage, but something like 50% more women were back in the hospital within the first year after an MI versus men with other issues. And I wonder about this compassion piece of it. I just wonder. And obviously, the other things we know is that a lot of research for many years was done with men. So there's probably stuff there too that's important. I believe this: no one deserves suffering ever. And we as healthcare clinicians are all works in progress. I know I still am. And, when we see it, know it, focus on it, we can grow and be better at it. I do want to talk about this since I have you with me, and I know we're going long, but approximately 53% of US physicians are suffering burnout symptoms at the moment. What is that coming from? Overwork, cynicism, frustration, lack of meaningful relationships in the workplace. The cynicism from loss of autonomy, and we know what that does to our patients. We know what that does, and it's being taken away from healthcare workers, physicians specifically as well. Insufficient support or unattainable goals. And I push back all the time when people say, well, you need to make them do this or you need to make them do that. I used to, when I was on inpatient rehab, well, why aren't you making her stop smoking? She's pregnant. My response, I always know, if anybody says that, is I can't make another human being do anything. What I can absolutely guarantee is that I will connect with her, build a relationship of safety for her, and when she's ready, help her move in that direction. I just push back all the time. And when you hear a physician, a nurse, a counselor say, I'm going to let them or allow them, I just smile, because that's not the truth. You have no power to let people or allow them. The truth is they will do what they want. So ultimately leading to withdrawal and depersonalizing and detaching because of this. And you see the stats are heartbreaking. And it was interesting that unlike the rest of I think this is really important to talk about, unlike the rest of the population where there tends to be more completed suicides by men significantly than women, when it comes to doctors, physicians, it's the same percentage. Wow. Just look at this. In the general population, males, you see it's there. Yes. However, female physicians have a rate equal to male physicians.
Well, and Cheryl, as an aside, my wife ran the physician well-being program for the state of Indiana for over 30 years. And again, on occasion, dealt with a physician who died by suicide. But what isn't in the statistics is the vast majority that were maybe connected to their substance use.
Oh, yeah.
Issues.
Yeah, you know. Substance uses. And I would say that we focus on substance use. We're not focusing on the toxic stress and trauma that led to that too. Mm-hmm. It is we don't go to the source. We see the behavior that's happening, but we don't go to the source of where it's coming from. Yeah. And we know from all that work with childhood trauma and the ACE study that Felita and Ann did that, you know, folks who've had significant childhood trauma in those first 5 years, they are much more vulnerable to additional stress in their life. They saw that with Vietnam veterans. The ones that had had childhood trauma were more likely to have PTSD and have significant problems. So that's going to happen with physicians too, right? And nurses and anybody else. It's going to be more difficult for some. There is a parallel process of clinician burnout and system burnout. This connection is vital, and it does trigger the reward center of our brain and brings resilience for us. And the question was, do we do this in high stress environments too? Absolutely. Those that are under the most stress need the compassion the most. That was a research that was done from the University of Rochester, not far from my window here. I can almost see where they are. And a compassionate culture in the workplace also supports less burnout. So you can see there, physicians who had the most dissatisfaction with their relationships with patients had a 22-fold risk of burnout. Last but not least, Dr. Kristen Neff's work on self-compassion. We have to offer the same compassion and kindness to ourselves that we would offer a good friend. Know that failure and imperfection are part of the human condition for all of us. And when you're struggling, think what you would say to your friends so that you can say it to yourself. Compassionate care belongs here, and I'm going to stop sharing. I got all kinds of other slides that say goodbye and how are you and who I am, and I'm not going to do any of that to you. I've already put you through this, so that's enough. You can't tell that I am compassionate about this and passionate about it. Yeah. Okay.
Cheryl, anyway. That was wonderful. I loved it. I'm going to share this with my daughter who's a second-year resident at Children's Hospital in Los Angeles. I'm gonna send her this stuff.
Please do. And I have 2 granddaughters going into medicine too. So I am watching it in the next generation as well. I'm going to thank you for saying that. I'm going to send it to my granddaughter when I finish here.
Yeah, because she just accepted one of the chief resident positions for after she finishes. And I'm going to say, hey, Abby, this is a mentor. This is what you might want to consider doing. Not need to, because she can't be told what to do anymore.
No. Never could, probably.
That's right. Well, I always tell a story that she's the younger of our 2, and when I share on autonomy, Cheryl, I was having this flashback when you did this a while ago. I'm going. My daughter was about 4 when she turned to our son, who was 6, trying to tell her what to do. And she said, "You're not the boss of me." So I use that story that autonomy is generated at a very early age.
Oh, yes. And we help it, don't we? I mean, we do help it too, hopefully, if we're doing it well. Yeah. And what I learned then, I wish I knew all of this when I started with my children. I was better with the grandchildren around all of this. Yeah. Anyway, well, thank you for your time and for listening to me through all of this. And I'm really trying to bring their thoughts to you, not so much my own, although I mix my stuff up all over the place. You notice that. I can't help it.
Cheryl, bravo. Very nicely just organized and presented. Are you making the slides available to our group as well?
Yes, you can. They're my slides from my job. That's okay. I'll just send them to you as a PDF. They're already out there all over the place. So yeah, I will do that. It makes it easy to kind of figure out what you might be interested in looking at too in the book, not having to read it all.
Very powerful. Could I have a quick question, I hope, about your discussion of empathy and compassion and the differences, because I've been struggling with, and we all know there are, maybe 200 definitions of empathy. Mm-hmm. And so you're using empathy as a feeling, mm-hmm. and it's confusing to me sometimes because so much of us, or I've spent my time teaching empathy as reflective listening, mm-hmm. right? So somebody, you can experience and understand what somebody is experiencing, but the empathy or accurate empathy is my statement that Mrs. Smith, I really see that this is deeply troubling for you. Mm-hmm. So that's an empathic statement. I may be that's one way that I've defined an empathic statement. There's compassion sort of in it. I'm just sort of, how do you distinguish the two, or are they the same? Once you've made an empathic statement, is that compassion?
Yeah, and I'm taking it from these functional MRIs that were done. So it's telling us where in our brain we light up, right? So when I recognize somebody's pain, right away, my pain center lights up. That's not really an action. That's a feeling, isn't it? It's something that comes to me in a way that I can feel there's something hurting, with the suffering. I can feel the suffering. Right. When I go to compassion, it's so cool, because when they see them go to compassion, like, okay, I can feel it. I know it's their pain. I can separate from that. I know it's their work. I can walk with them to do it, but it's not my pain, and I can't make it happen. I can just be with them and walk through this. All of a sudden, my reward center lights up. That's what they saw. And that is something we can stay in. And what they recognize now is if we don't learn to do that, you can do 2 things if you're in a lot of situations where there's pain and suffering. You can turn your empathy off. Just turn it off and not feel it. Or you can feel it, but learn to differentiate and move to the compassion, the action. And when you do that, and all the things about MI help us do this, because we know that we're collaborating. We know that it's the other person that has their own answers for how they're going to get through this. We know all of this. And so we're able to move to that place of partnering and being with them, right? Rather than having to fix it. And that's why I differentiate between acute illness, things that you can fix really quickly, broken bones, surgical things that you do really, the lacerations, that kind of stuff, because you can do something about that. I'm talking about all that other stuff, the psychological stuff, the chronic illnesses. We give people no time to grieve when they find out they have diabetes. It's just, get you to all the people that you got to learn. There's something there we got to do. I think back as a 74-year-old, if I had had diabetes when I was 24, how different my life would have been. And I would have wanted that compassion and that grieving space to know that I got to carry that for the rest of my life, right? It's a big deal to get a chronic illness. And it's even bigger when you know that from the trauma research that Fleety and Anda did, that the folks that get autoimmune diseases and more chronic illnesses are often the folks that had a lot of childhood stress. Mm-hmm. It's connected. It's a dose response. And so those are the ones that need the most support and caring. Anyway, you can't tell. Here I go again. That's why I keep working. This is good, right? We're not done yet. Won't be my choice when I am either. So it's what it is.
Cheryl, no wiser words were said of, we're not done. There's a lot of work yet to do. And boy, through the screen, I feel your passion and compassion, and just a deep bow to you for the work that you're doing, and inspiring, and just a wonderful presentation. Just so much, this combination of story and data, and the impact that compassion has with all of us living with chronic illness, and how that matters and shows up in the data. Just very, very powerful. So thank you so very much for sharing.
My last words I'm going to say is that I have tremendous respect for everybody working in healthcare, everybody. And when I say about, not having empathy I understand. I live it too, and I've lived it. I understand. I do know that when you can get past that and stop feeling like you're not making a difference, and stop feeling like you can't get what you want from the patients you're serving, it's a different world. Yeah.
I just want to say thank you. I have to get going too.
Yep. I'll send that to you, Liz.
Okay, that would be wonderful. Thank you all so much. Glad I made it this month.
I'll get it to Heather, and then she can send it to you. Okay? Okay.
Wonderful job. Thank you.